let us start, I think, because, so technically, good morning and good afternoon, everyone. And today we have Dr. Rajani Singh with us, and welcome to the monthly Cybersecurity and AI Innovation in Healthcare seminar series hosted by SAC Cybersecurity Research Center. And this seminar is also a part of one of our sponsored grant, that is the NSF MSCC. So today's topic is use of AI in scarce healthcare resource allocation during public health emergencies. So Dr. Rajani will talk on this. So let me give you a quick overview of the talk that Dr. Singh will discuss how AI and machine learning can help to analyze emergency tweets by identifying actionable requests, extracting useful contextual information, estimating urgency, and prioritizing cases for expert review. The main idea is not to replace human experts. That is all of our AI is that we are not artificial intelligence, we are the augmented intelligence people, but to support them. AI can help reduce the burden of filtering and triaging large numbers of requests. That is very common on social media. And how the final decision remained with the healthcare professionals. So in this talk, she will put more emphasis on how such AI augmented human systems, that means in other words, we can tell it's human machine teaming, can improve the efficiency and social welfare of emergency response when demand exceeds supply. So let me briefly introduce Dr. Singh. Dr. Singh is an assistant professor of Department of Digitalization at Copenhagen Business School, and she is associated with the Center of Business Data Analytics. She holds a Ph.D. in mathematics from the University of Warsaw, Poland, and her research lies in the intersection of dynamic games, optimal control and optimization, with a strong emphasis on real-world applications such as resource economics, healthcare, renewable energy system, and digital markets. Most recently, her work has expanded toward data-driven and informed decision-making. And prior to joining CBS, she was a visiting researcher at the University of Waterloo, Canada, and worked as a researcher in the Polish Academy of Sciences. So, which she has not written in her bio when she shared with us that I know she is a seasoned researcher and she has a very good publication. You can just type her name in Google and find out her work. And yes, Dr. Singh, the platform is yours. Welcome.
Thank you so much for the kind information. I didn't know that much about myself, but yeah, I'm really glad to be here and thank you so much for the invitation. And I hope I will, by the end of this talk, there will be something very interesting to all of you. And let's get started. So, as Professor Pushpita already mentioned, that it is artificial intelligence in healthcare resource allocation. Why this is different than the other ones? Because in healthcare resources, there is a lot of scarcity. And I don't have to talk about me. I just want to mention two things that right now I am a co-director at Pioneer Center for Artificial Intelligence in University of Copenhagen, Department of Computer Science. So it's like they have a different programs. So I'm co-directing together with two fantastic colleagues and on the topic of machine learning, incentives, and market. The other thing is, if any of you are interested in interaction between the optimal control theory and machine learning, then I'm in the cost action management committee. So I'm representing Denmark, and I'm the only one till now in Denmark who is representing this control theory and machine learning combination. And they are highly interested in data-driven decision making. So that's the other important area to combine the traditional analytics together with the data-driven. And the research interest is basically, since of course I'm affiliated with Data Science Center, so data science is priority. I really love working in natural language processing and the intersection of artificial intelligence. So these are a little information in case if some of you would like to do something in a collaboration. So, what we are going to talk about today? So, first hot topic is the SOS analytics from social media. SOS messages are it's called a urgent messages. So, if someone says it's SOS, means it's a most urgent situation to work on. Then we will talk about the scarce resource allocation when we have a scarce healthcare resource, and we will particularly talk about the COVID-19 situation. Then, how we can coordinate as a human or the healthcare expert together with AI when the AI has more trade-off compared to the human. Then, based on these SOS messages or the SOS information, how we can prioritize. So that will be in the part of urgency scoring. And then I'll talk about some important issues such as the bias. It could be human bias, it could be AI bias, and a little bit on the privacy issue. I worked previously a lot with the privacy, but I think that today's talk I would more prefer to concentrate on the AI and the human collaboration in such situations. So to start with, basically, during COVID, and we all have feel this very strongly. We can feel this strongly because we have been in such a situation. So during COVID, either it's a Facebook, Twitter, or the different social media platform, there was a lot of information. Lot of people are tweeting or messaging and getting a request. We need some oxygen cylinder. We need some different healthcare resources. So the problem was not a lack of information, but the problem was we had a very limited healthcare experts if they want to really take care of these messages, and based on these messages and requests they can provide the resources. And what was the main problem or the challenges? Lot of noise in the data, so much information, no structured format, time pressure. Because during the COVID, if someone has a sudden drop in oxygen, the blood oxygen, they need immediate help. They need a immediate oxygen cylinder. So the time pressure, like how much time does the patient has, and how much time the healthcare experts have to react, is really, really important. And the high stake decision making, basically whatever decision the healthcare professional will make, it will have a huge impact. In a way, if the decision is a little bit wrong or not timely, it could lead to a very worst scenario. So this was the whole motivation of this study, that how we can utilize, maybe if this is just a one situation, we never know, we can have some different situations, but in such a cryogenic situation, how we can use the AI. So to start with, I just want, because I don't want to have a one-to-one only, like I'm speaking with the laptop. No, I think that it's a good idea if you could try to give your response on these ones, so that we can have a very open discussion on these topics as well. So for that, what you need to do, you can just scan this code, QR code, and then you will already have these questions. And if you have this one, then please respond. We can see the responses here. So I'll give you, I think, few seconds or minutes. Sorry. Yeah. So if you saw a social media post, it says urgent, need oxygen cylinder immediately. And I hope during the COVID, if you are lacking the context, then during the COVID-19 Delta variant, which was very prevalent in India actually, that there was a lot of people who really need these oxygen cylinders. Okay, so that's a great. So I can see that you guys are trying to uh, put your opinion on that one. So the best answer, and actually that is true, that it depends. I will talk about it in a moment. Let's give you the second question. So let's say, of course, due to the data protection, I just masked some of the things. So when it says the phone, means there was a phone number given. When it says address, there was a real address. So I just replace it with the placeholder. So these are two tweet messages. Take a minute, read these tweet, and if you were a healthcare expert, which tweet would you prioritize? Would you help the patient in tweet one, or would you help the patient in tweet two? And this red one is the tweet one, and this is tweet two. Let's see the responses as well. Yeah. And here we are not, here my idea is not to check your knowledge, the healthcare knowledge or the medical knowledge. It's just if you are a, let's say, a human expert, would you really go with that one? So great. So majority of the votes are about tweet one. Okay, I didn't give the option of three, which is it depends. Otherwise, most of the majority would go to the it depends, right? All right, so very good. So here, basically, uh, can I get one or two opinion on why do you think, why, if you have voted for tweet one, what was your reasoning behind? Why did you choose that? Anyone? Because I just want to know one opinion who choose tweet one and maybe one or two opinion who choose tweet two. Or you can write in the chats. I can read it here if you want to go with the chat. Yeah. So anyone?
I think that for the most part, the reasoning why to put one, the amount of information that's contained within. You don't want to provide uh, healthcare resources to someone that doesn't have need. And so, for example, in tweet number 2, it actually says oxygen support needed, but in tweet 1, it says oxygen levels and need oxygen cylinder. So it would depend on what your role is in the healthcare service providing framework or network. And so
Mhm.
if you're responding based off of oxygen levels, or if you're basing off of, for example, in this second tweet, it has this person has COVID. So you would have to justify whether or not it's reasonable to give that person oxygen. One oxygen level is 60, the other is 82. But does COVID have an effect on that, whether they would need more support or not? It just would depend on how you analyze that particular information in the tweet.
Exactly. I think that was my point, which I wanted to convey. So thank you so much for the good answer. In a way, like you have actually explained the reasoning behind. So one thing is the first person has given a more precise and more information that is really needed to the point. And of course, depends on some people would prioritize the patient one and some patient would still prioritize the patient on two. In the second one, there is a one thing also, it's called they don't need only one resources. So in the first one you can see that they only needed oxygen cylinder that could be also used at the home setup, while in the second one they need two resources, actually oxygen support bed either in the hospital or the oxygen cylinder. So there are so many varieties. So what my whole point here is actually to show you these tweets and all, and that this type of situation was happening during the COVID-19 time, that the people are sending a lot of messages either on Facebook, Twitter, and then the people sometime, even the healthcare professional or the person who knows how to give them help, they are trying to reply and help them. And what if such data can be really used for the real time manner? So here we can see that the main decision making problem is even at an individual level. As a human, either it's a healthcare expert or we struggle with the verification in a way whether the person who is tweeting, is it really genuine need. The second thing is prioritization. The second tweet is more about, like, the second question was more about whom do you prefer. So these are a very sometimes subjective also. It is not always objectify, but sometimes it also depends on who is making the decision at what time. And why it's a problem or challenge? Because first of all, there is a no structured way to send the tweet messages. People can just write anything that they want to do. And you can see a different structures here as well. Then the second thing is emotional language is not really the clinical severity. The people will say urgent, 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 but depends on the situation. You cannot really reflect the emotional language or the tone from the tweet to the urgency. Incomplete information, of course, some people prefer to have more and more information about these health condition of the patients, but some of them just type it quickly maybe, or very brief. And the level of uncertainty, in a way that when the person is tweeting and the time that they are providing the help, how much is the difference between these timing, and how the situation getting worse or better in between of the patient. Then the main important issue with the healthcare resource allocation, we are comparing with the other resource allocation problems in economics, in business, finance, is that in healthcare resources, they are very limited. And especially in these type of situations, there are much more need. So basically the demand was really, really huge, but the supply was very less. And you can, of course, visualize it in a way that what if the healthcare expert get such type of post, 1,000 amount of these posts per hour. So it's a very huge data set. Then there were two challenges actually. So when we addressed this situation, we had two challenges. So core challenges is very generic one, that massive amount of information, limited resources, as I mentioned, noisy data, lot of different information, there is no proper structure, and most importantly, it contain a personal information. So which could have a very serious privacy breach. And then the real-time decision making is the other main challenge. If you looked into the natural language processing side, because once we collected these data set together with our team, we had this huge set of data, and then each of the data was scrapped from the web or the platforms, and then we see that there was a lot of issues to analyze this data. You cannot directly analyze each and individual data. They were in thousands actually. So sometimes the people use, like, some of the point that we have, I'm trying to give you an idea, is the informal abbreviation. Sometimes the people use the location very short. They thought that everyone knows that. Missing important information, like the healthcare information, let's say, and missing the important information, ambiguity, because the patient says a lot of things, but a lot of ambiguous thing as well. So we need to mask it, because if we want to provide it to the AI and to the third party, we don't want to reveal the personal information. So we need to do a kind of masking. And this here, this is the original tweet that we were working on, is here. So this is the handle who were sending the tweets. Need is the oxygen cylinder, patient name, there was some exact name, the contact detail, address, all these things are like just open to the public. which is not good. So we need to do some kind of masking, and which itself has a huge issue. And then, of course, sometime these are just a sample here, but sometime what happens that even for the same patient, there's a multiple needs. If the patient has a lot of comorbidity, let's say the person is diabetic, they have a chronic disease, asthma, then these are the things that how you will really prioritize. Every case is different. So these were a huge challenge. So what we wanted actually, what we envisioned with these data set, that we want to create a ideal decision support system, and where uh, when we move from one stage to the other stage, we will try to reduce the uncertainty to the maximum extent possible. So what should be an ideal situation? That okay, what are the what are the resource needs from the tweets? Uh, so we have these tweets, we analyze the tweets, we know what information do we need. So basically the patient health state, and then what they are really asking for, and then based on these information, we just prioritize the number of tweets. Like, okay, let's say we have 100 requests and we have 10 or 20 resources. So which 20 patient will get these resources? And then based on the urgency scoring, we will do the prioritization. And then finally, we want to have the decision in the hand of the real human, the healthcare expert. So they will review the decision and then they will get it. And then how can AI help here? Because these are the things that you can see, but when you have a huge amount of tweets, huge amount of data, you need a kind of automation or you need some helping hands. So basically, where we can use the AI. First of all, AI in real time tweet filtering, information extraction we can use, and then human and AI both can do the urgency scoring in a way to train the system. In the beginning, we plan to have let the human do an field experiment, let the human decide on the urgency, and then let the use the AI models and do the urgency scoring and see how many times they have a really different opinion on that. And then again, human in resource allocation, and ultimately what were our objective? To maximize the social welfare, maximize the lives of the people as much as possible, or saving the more lives. So here you can see the more detailed version. What could be the AI responsibilities, where the human responsibilities belongs to. So information, entity, priority, and uncertainty. These things you can easily automate using the AI. And any large language model can do that, or you can develop your own bot who can do that. Then in the human responsibility, because they with the healthcare decision making, lot of ethical issues are there. And then the human should always do the final allocation decision, because there are sometimes the exceptions that no one can, that AI cannot really trigger that one. And the accountability. So what is our proposed framework? Basically, and here we use a two different stage. I will let you give an idea in a few moment in a next slide actually. So here we have these SOS tweets data, which is a huge, and then we use the natural language processing and text analytics techniques. We pre-process the data, we try to make it as much as possible in the standard form, and then we consider a different type of heterogeneity among the users. Users are the health experts. So first of all, since we also want to see if we automate the urgency, how it will give us the reason. So as a benchmark in a way of AI models. Then one heterogeneity lies in the human AI literacy level. Not all the healthcare experts are very good in the dealing with the technical things with the, let's say, AI chatbot. So there is two level of literacy, how much they are used to with the AI use. It's a low or high. The second thing is within the healthcare area, there are different level of domain expertise. So for example, the compounders, the nurses, the doctors, or the different people, they have a different level of knowledge to make a decision. So it's either low and high. And actually during the COVID time, each and every resource is being used within the healthcare experts. Then we have the utility function, which means because we need to somehow quantify our objective. So to quantify that, we have used a kind of measure which is called the quality adjusted life years. And in short, it's QALY score. So we calculated the QALY scores based on these things. And then ultimately we want to choose an optimal resource allocation model that maximize the joint utility, means the joint utility of all the patients or all the tweets. So that was a kind of overall idea about the proposed framework. And to give you some idea about the data set, what data set do we have? Actually, we have reality in thousands of data, but since we want to run an experiment with the real human on the field, so we want to have a decent amount of the sample size. So the data contains the unique ID of the patients, the tweet, age of the patients, disease, which means we can also get somehow idea about whether the patient has any comorbidity or not, the place in which geographical area they belong to, what they are requesting, what is their need, and need could be like oxygen cylinder, ICU bed, ventilator, or remdesivir medicine at that time, and then of course the date and time of the tweet. And then based on the date and time, we have created a timestamp actually, so that we can filter based on the timing as well. So when we do some EDA, exploratory data analysis, we found some insight. Of course, there were many more, but just some of them. For example, there is no formal language to write a tweet. In such a case, the people are very like sentimental heavy. They have a lot of issues with the families, health and all. So they can just write whatever they feel to do at that time. There was a different way of writing duplicate post. Some people just write it with the different handles, the same need, same patient, but maybe the 3 or 4 family member posted it so that it can somehow reach to the right people, and missing the important information sometime. So what data we finally use for the analysis, which has a 382 observations, and we generally restricted to the Delhi NCR. Age is between 18 years to 80 years. I mean, we assume that because you cannot really make a model without some assumption. So the first assumption was we assume that the expected life of a person is 80 years, let's say. And from adult, 18 to 80 is our range that we choose the data. Because for the child, the need is very different. And resource need, for now we have chosen for one particular resource, which is the oxygen cylinder, and we assume that we have 382 requests basically, and out of that we have only 100 oxygen cylinder in our hand at that time. And then how we are going to create our resource model, optimal resource allocation model. Then to do the masking of the data set, because if we want to expose our tweets or the data set to the human in the experiment, we don't want to share the personal information to be ethical. So we do mask all these 382 tweets, and we use the regular expression and named entity recognition. These are the two NLP techniques, natural language processing technique, which can be used for the masking. Since we want to make our even masking interpretable, because you can also use so many advanced methods for masking, but we want to make it as much as possible to be interpretable. That's why we generally rely on these main foundational masking techniques. So this was about that data. Then here that I wanted to show you what is the exactly rough idea we want to do. Basically, first we want that a human, which is a kind of healthcare people, they decide on how they are saying that this tweet is urgent. And the urgency, they have three level: low, medium, or high. So given a tweet, they need to decide whether the tweet is low urgent, um, low in urgency, medium in urgency, or high in urgency. So after getting these urgency score, then, and this is needed because we want to see how it will help to change with the QALY score, because our QALY, this quality adjusted life years, it is not just the number of years, survival years multiplied with the number of the quality of life, but it's a weighted how urgent it is for particular people. Then in the second stage, we created a resource allocation model where we feed these urgency score and it calculates the social welfare for the tweets. So that was the methodology. So here you can see the one experiment, and this will give us an idea of the heterogeneity. So so we have created an experiment, we run an experiment, and then the first question is, are you an expert in using the artificial intelligence? So yes or no, so which will give you low or high. Then the second one is, are you a triage expert? Means what is your expertise, domain expertise. So together with these four combination, you will see that there is a four possible treatment groups. High, when the AI literacy is high and the triage expertise is high. And the second one is when the AI expertise is high, but the triaging expertise is low. And then so on. So that is how we try to get first the idea of the heterogeneity, and then we ask them to do the urgency scoring. And I'll also talk about that in a moment. The second model, and then so that was in the first stage to get an idea, but of course we haven't done urgency scoring yet. The second stage, we want to create a mathematical model of optimal resource allocation. So where we have such variables, so number of patients, the medical urgency, as I mentioned, low, medium, high. The P1 is the variable which tells the probability of patient surviving or maybe recovering with oxygen. P0 is the probability that the patient is surviving without oxygen. And when I'm saying this with oxygen, without oxygen, it can be generalized to probability of a patient surviving without giving the resource, without the resource, or with the resource. Sorry. And then here SI is basically what is the expected lifespan of the patient. So which, as I said, we assume that on an average, a person lives 80 years. So 80 years minus what is the current age of the patient that needs the resource. Then the quality of life. The quality of life is basically if the person is get treated, how well he is going to live. So basically, if some person has a comorbidity, let's say the diabetic or chronic disease, their quality of life is somewhere less than the quality of life when the people don't have any comorbidity, and it can have any value between 0 to 1. And we assume that the people who don't have any comorbidity and disease before the COVID, then they will have a 1 quality of life. And if the person has like 2, maybe 2 disease or before the COVID, then they will have a half, 0.5 as a QI. Then the allocation decision is 0 or 1, basically a binary, either to allocate or not allocate. And K is the maximum resource capacity, which means the number of oxygen cylinder, which is 100 in this case. Then the utility is basically how you get the expected gain. This is just some mathematical formulation that what if the patient will get the resource minus not get the resource, expected lifespan into QI. And then these urgency, which the human is going to do based on the experiment, low, medium, high, based on every tweet, we have scaled it into a numbers. So because this urgency scoring is a proxy for how much this resource can improve the patient survival chance. And as I said, the objective is to maximize the social welfare. And in that case, our social welfare function is just an average of the expected gain in QALY. So it's this one. And then the output is basically based on all the tweets, let's say n tweets or 382 tweets, which tweets get the help, which tweet does not get the help. So 1 or 0. So these values will be either 1 or 0 actually. But we will get the whole profile for the whole tweets. Then, of course, there was a lot of information. But now let's see a simple scenario. There is only 10 ICU beds. The capacity is 10. And there are 25 tweets asking for the ICU bed. What would be your first filtering criteria? Sorry, yeah. So what would you think? So here again, I can see that there is a lot of difference in a way that the people have a different thinking. So this is exactly the human bias actually. Yeah. So highest urgency, verified request. So there is a different way. So basically, the problem is, of course, there is a lot of uncertainty. And then, as I mentioned before, emotional intensity is not the clinical severity. Then there is a visibility bias. Which tweets are shown to the healthcare expert and how they write the tweets also. For example, how they exaggerate, uh, how they show the condition. Maybe the person is not that urgent, but they write so urgent everything. They just extrapolate everything. And then sparse medical context. So these are the things that are still the problems. But I think based on this one, uh, how the what could be the possible signal? Medical terminology. How much they are providing the precise medical information, the temporal escalation, how frequently the patient position is changing. Sometimes the people do a repeated posting. So, what is basically here the challenge? The ground truth urgency labels are difficult to update. There is a sure short formula of the ground based urgency labels. So, that is why we want to get a really huge idea about how the people think. So that was our second part, that what we do, we just run the experiment and on these four treatment groups. So first we get their heterogeneity level, what is their AI expertise, domain expertise, and then since we also run these tweets to the AI model. One was the reasoning model and one was the non-reasoning large language model. So we already have an AI score. So let's say this is the tweet and the AI provide a medium urgency is of this tweet. Now, this is just an additional information, the AI recommendation. Now, here it's the human. We want the human to decide what they think. Do they think low urgency, medium urgency, and high urgency? And of course, we also want to get some extra things, which is not really the focus for today. So I'm just skipping this part. So basically, now we are giving the tweets and then doing the providing the AI recommendation and then getting the urgency scoring from the users, the human. And these human are basically the healthcare expert whom we are running the experiments. So the problem that I mentioned here is the bias in the visibility and allocation. As I said, the tweets receives different exposures due to how they write, how much they are socially connected. Basically, sometimes the tweets can spread in a moment, how they can be retweeted so many times, and then platform amplification. Sometimes that is also a possibility. And then how much the people are good with the digital, using the digital tool. Not every family has the same digital literacy to interact with the different posts or the media. And then, of course, depends on the geographical area. And as I mentioned, even the healthcare expert can also be biased. It is not only the AI that whatever you put the algorithm into the AI will just talk about that. No, but the human can also be biased, and the bias could be a differently measured. And then, so the problem is optimization, this resource allocation optimal problem over the biased visibility signals can reinforce the inequity. So that is still the challenge. But to combine the AI and the human, we want to reduce the bias also as much as possible. And then the second one is, I didn't get the question, but I think this is a very obvious question. Why did I choose the QALY as a utility function? So basically, since the objective, what we want to achieve are also the ethical commitments. Do we want to prioritize the people who are, let's say, female versus male? Do we want to prioritize the older people, or do we want to prioritize the let's say the younger generation, because they have a high chance of living long life? So basically there are so many ways how you decide your priorities. And then there is no prioritization rule, no utility function that could be value neutral. And there is always a lot of backlash even using the QALY. So, and when we design our this decision support system, it already encodes the utility function. We need to make some fairness assumption, what was basis, and then till what level we can go with the risk. And then here, as I mentioned, some of the way, the maximum survival, it has a side effect that it can disadvantage the vulnerable groups. First come, first served. Mostly in medical terms, the people use the FIFO. So first in, first out. And it is actually the this one, but it ignores the urgency. Maybe the next people in a row have much severity, and that can be saved if they are treated earlier than the who come first. Geographical fairness, of course, it can reduce the efficiency and the fast response. Some people are very digital literate and they just know how to deal with this digital platform, but and also they know sometime in a wrong way that how to extrapolate the situation. So which can increase the information risk. Sorry, misinformation risk. Yeah. And then here for the social welfare, what we did particularly, basically, of course, we know that different optimization objective, whatever we choose our utility function, will provide the different social welfare outcomes. And then, sorry, okay, I can take a question a little bit later, maybe. So, and then different technical architecture also shape the societal outcome. And every system reflects the priorities, the ethical trade offs, and what are the assumptions that is made. So, in our case, this is the result of our case. We have tried a different methods. So, one is the FIFO, first in, first out. We found in that case, using the urgency scoring, calculating the weighted QALY, then taking the average, we found that the total social welfare is this amount. If the human is doing urgency, means the real healthcare expert are doing this urgency scoring, and based on that, we calculated that this is higher than even with the FIFO. And here what we assume that if every tweet is same urgent, like we assume that every tweet is a maximum urgent, and then we want to just prioritize based on the timestamp, then we got these ones. So basically, in that case, we have get the different opinion, different results. And where when the human, and when I'm saying human urgency score, it's not the only that human individual is doing, human with the use of AI. So human can see what is the AI recommendation, and then they provide there. So it's actually human AI combo. Now, the question to you is, what do you think? What should the decision support system provide the most? Urgency, fairness, survival probability, or first come, first serve? What is your opinion on these ones? Urgency, survival probability. Okay. And honestly speaking, fairness is something which is almost impossible to achieve in such a situation, because there is no concrete, unique answer. It's very situation dependent, right? So, yes, so basically, here you can also see that so there is a different way to get so I think it is depends on the person, it is depend on the people how they wants to make their support system, decision support system, and what the healthcare expert prefer to do that. And then there is some issues, as I said, that these tweets contain a lot of personally identifiable information, which is called PII in short. And then, because we want to do an experiment with the real healthcare expert, so if we provide them the right original tweet, then it's a problem. It will give a bias. The second thing is it will have a privacy breach. So that's why we need some type of method that we can share maybe the direct tweet, because honestly speaking, doing a masking was very time consuming, because there was no fixed way of a structure of the tweets. Every tweet needs to be masked differently. And then there was a risk, as I said, when you use the direct tweets. So if you guys are, because I know here the people are also working in the privacy area, so I think it would be worth uh, exploring, first of all, how much data should be stored. What are the important information that you need? Do you want to store the whole tweet, or do you want to take just the main entities and then just that's all? You just remove the other information to avoid the data breach. Then, what level of anonymization is sufficient? Can utility be preserved under the privacy constraints? So these are the worth exploring question for the privacy people. And then what should be the responsible crisis data governance? We need a design principle, the data minimization, purpose limitation, access control. Privacy is a really important issue to work on that one, and you can use a different methods of the privacy preserving crisis analytics, such as federated learning, where the data never leaves the system, where the one person who stored the data, it could remain to with them, and the people can do the multi-party computation. Then there's a differential privacy for the cryptographers or the cybersecurity people. Then how you can do the secure data sharing, because of course when someone put their data publicly, it doesn't imply that the we have a ethical permission to just spread that information further. So what are the key takeaways here? Social media is highly valued, but this data has a very noisy crisis signal, especially in these triaging situations. They are real time, but unstructured and uncertain, with a lot of noise in that one. But what is our whole goal is that using AI, we can somehow automate some of the system. You can reduce the cognitive load from the humans and give it to AI, such as filtering, prioritization, and the confidence estimation. Because if you have a AI recommendation of the urgency scoring and the human do the same, and if they matches, the sometime it get a confidence more and more. But our final important point is that human judgment is important. They are not replaceable. For example, they have ethical reasoning, accountability, and the contextual judgment. So they are still better in these ones. And especially when I'm saying human judgment, basically the healthcare expert. So AI can help in so many ways and can faster this process, but can never replace the human. And then the final question is, would you trust an such AI assisted allocation system? Or do you think is it really a need of such system? Okay, so only with a strict oversight, yes, that is true. And definitely we need some system. But as we said, that this is just the idea that came out with all of with the whole partners in this project. But there is still a lot of things to do with these ones. There's a lot of things to. This is the first iteration. Over the iteration, it can change a lot. So my final takeaway is the future challenge with a lot of AI is it's not AI versus human, but it is more about designing the effective human AI coordination under uncertainty. So this is the main key takeaway that I wanted to provide, that okay, there is a lot where AI can help in the healthcare, especially in this trying situation, but we need to be smarter to find the best combination of both. So thank you so much. And then I can take the question. I think there was some questions in the chat.
Thank you so much, Dr. Singh, for your presentation. Wonderful, very informative. Yes, we have some questions. We can get started. We have some in the chat. You all can also get off of mute if you have any questions, or you can use the Q&A. We can go to the first question from Lashara, Miss Lashara. In your design, how do you capture any legal responsibility for optimization?
Yes, I think as I mentioned that these ethical challenges are really an important issues in a way that what are these legal? Of course, you cannot just give it directly that okay, someone is asking and you can give. But I think this will give you at least a proxy to check whether such need is important. Because during the COVID time, not all the people can get the help.
Yes, thank you, Lashara. Thank you so much, Dr. Singh. Great. Any other questions, if anyone has?
Yeah, very good presentation. Very interesting, very unique. With things like trustworthy AI, do you see the allocation system? Do you see that being something that's app based?
Mm-hmm. What do you mean by app-based? Can you just
Yeah. So if we were inputting information, if we were looking at information, could that be designed and developed around kind of an app based platform?
Yes, definitely. This is actually the decision support system that we envisioned is actually such things that to develop a kind of app which could help in further.
Thank you. Thank you. Very, very interesting work.
Thank you for your question, Mr. Bhatia. Thank you, Dr. Singh. We can take more questions.
And I'm also opening the chat in case if someone has questions. Yeah.
A wonderful presentation, Dr. Singh. Very informative, very nice, interesting information. And thank you for your time. It's
Thank you
very
so much. Thank you so much, Professor Uttam, Professor Pushpita, Professor Asma for inviting. And I'm really glad to talk about it, right? And yes, so thank you so much.
Thank you. Thank you so much. Okay, so we'll go ahead and end the session if there's any more questions. Yes, thank you.